Okay, well, welcome. I think we'd like to first just introduce ourselves. I'm Sean Haskett. I'm a board certified OBGYN. I've been in practice for 17 years, primarily focused on women's health. And I've got Jen Krebs here and Tennille Cloward. If you guys want to introduce yourselves, that would be great.
Yeah, so I'm Jen Krebs. I am a certified nurse midwife and advanced practice nurse. I've been practicing for 15 years, and my specialty is, again, obstetrics, gynecology, but I also provide primary care for women throughout their lifespan.
And I'm Tennille Cloward. I'm also a board certified OBGYN. Been in practice right in the middle of these two, about 16 years. And I have a focus on women's hormones, nutrition, and their health and longevity.
Great, thank you. Yeah, and basically we've created this podcast to maybe help answer some of the common questions that we kind of come into when we're taking care of patients. This podcast is basically created by a clinic that we've developed called Valley Hormone and Wellness Clinic. It's kind of designed to be a little more beneficial to the prevention side of healthcare. I think sometimes in Western medicine, we get a little focused on the disease and maybe just prolonging someone's life. And we really wanted to kind of focus more on quality of life, helping to prevent some of the things that can make life kind of miserable for people. And so that's kind of where our passion is.
Yeah, I think I really love that we're taking this direction together because I think all of us are maybe a little bit disappointed in some of the ways that the modern medical system practices. That all of us really like to take, whatever woman is in front of us and look at her as an entire person. I really like to approach healthcare where I have a vast body of knowledge that I can use for each individual person. So some of my patients are really comfortable with pharmaceuticals. That's where they're at in life. Some of them are really uncomfortable with pharmaceuticals and they want to talk about supplements. So I need to have a very educated background in nutraceuticals. And anytime we're using any of these methods to treat a person and anything that they're coming to us for, we also need to look at their lifestyle. We need to look at them and their relationships and their spiritual practices. And their patterns of behavior and their specific individual desires, and cater with our knowledge that to that individual. And we need the time and the knowledge base to do that. And I think we're going to be really different in the way that we approach the individual in that way.
Yeah, it sounds like you really kind of want to meet the patient where they're at rather than pushing them into some, Western medicine necessarily mold that they have to be. So that sounds like it's a little more connected with where the patient
it takes a little bit more time to sit with a person and understand who they are in order to develop a plan of care for them.
And I would just add that, we have patients that come who have symptoms, they have diseases, they have things that need to be treated. But it's also important for us to take the woman who comes in who's actually feeling pretty good, but to be able to assess what is her lifestyle? What are her habits? Where can we help her so that she doesn't get into disease and develop symptoms and just help her maintain optimal health?
Yeah, I love the idea of prevention and optimization and just support.
Yeah. Well, and I think in the traditional medical field, and we've all practiced in that for a long time, one of the frustrations we have is just time. And that almost feels like you have to rush through appointments just because the way things are set up is they pay for a procedure, they pay for this. They just don't pay for the opportunity to actually counsel a patient and find out, what's going on in their life or where can I have an impact to help them get to a place where they feel better about things, whether it's emotional health, their physical health, whether it's, preventing some terrible future physical health problem they're going to have. So I think that's part of the concept that we're all excited about is just having more time with our patients.
Yeah, I certainly can't take one 55-year-old woman who needs hormone replacement therapy, who is the primary caretaker for her husband who had a stroke and, doesn't have a lot of other family support, and put her in the same box and shove her in the same treatment category as another 55-year-old woman who's been a bodybuilder her whole life and, loves to travel with her husband. And, the approach to sometimes the actual prescriptions we provide are going to be the same, but the way that we counsel them and the way that we incorporate their life into their treatment plan is going to be very, very different. And it's not something that we get a full opportunity to do in a really busy medical clinic.
The topic we kind of want to talk about in kind of today's podcast is hormone replacement therapy. And I think the format we're going to try to use is just try to ask questions that might be similar to the questions that we would get on an everyday basis, just seeing patients. And I think I'll be the devil's advocate a little bit and ask the questions and let you
Mostly
guys.
Because you're the most deviant.
I am definitely the troublemaker for sure. But yeah, I will try to ask some questions and maybe just open up the forum. I'll also try to contribute with kind of things that I've had some success with, and hopefully it will provide some information that's valuable. And obviously, this is a podcast. So we don't try to represent anyone's healthcare provider. This is not a patient-doctor relationship with anyone listening. We would encourage you to seek out healthcare from a provider, and any treatments or therapies would be from a provider that you're actually seeing as a patient, not from a podcast. We're really hoping that this is information that's helpful for you, maybe gives you questions to ask your provider, or if you want to come see one of us at the clinic, that would be great as well. All right. So first question, I think this is the one I get all the time. Patient will come in, they ask, hey, I feel like my hormones are off. Can you check them? How do you check those? And how do you know if my hormones are off, basically, is the question.
Boy, I have a whole spiel that I give about hormones and the term hormone. The first thing I tell my patients, and it depends on their age, and I think today we're kind of focusing on, the 40 plus, between 40 and 60s age group. The first thing I tell them is, so when my patients ask me about their hormones, what they usually mean is their sex hormones. They're usually talking about their estrogen and their progesterone and their testosterone. But I like to remind them that your body produces hundreds of hormones. Insulin is a hormone. Your thyroid produces hormones. And the way that these all interact together means a lot. So it's usually not a real simple explanation. And that the way that we quantify hormones in labs is a little bit different. We are a culture that loves numbers. We love to quantify things, and we love to attribute enormous amounts of value to those numbers. And the reality is that with some of those numbers, it means a lot. When I test somebody's thyroid hormone, it means a lot. But when I test their estrogen or their estradiol levels and their progesterone levels, it actually varies a lot depending on where they are in their cycle. The way that we quantify them is not terribly accurate. There's a lot of variation in that. If I did an ultrasensitive estradiol level and compared it to the standard estradiol level that we draw on women, they are very, very different, and the number of supplements that you take can interfere with that. But also, especially as we approach menopause, the way that our hormones fluctuate is highly variable. I think a lot of people think of menopause as this slow and steady decline in hormones, but what it actually is kind of a wild and erratic fluctuation in hormones. So there's highs and there's lows, and it can be very difficult to predict where they are. And the standard of what's normal is so wide. You can have an estradiol level that's 50, and that's as normal as a level that's 150.
Where are you catching it? Are you catching it at a high? Or are you catching it at a low?
And we have no idea.
Yeah.
And so those are hormones that aren't necessarily valuable to draw blood on and test. I can tell a 45-year-old woman that she is estrogen deplete because of her proximity to the age of 50, and because of the symptoms that she has.
Well, and that's a funny thing you say, because that's really the question. The question isn't what's the number of my hormones, is I'm feeling this.
Yeah.
Why do you want your hormones tested?
Yeah, exactly.
Yeah.
There's something.
What's going on?
What number are we aiming for?
Right.
I actually don't know.
Yeah.
But you
None
are
of us
aiming
know.
for
None of us
feeling better, right? That's really what you're aiming
Right.
for. And so I think that's the misnomer, is I
Yeah.
need this number to tell me I'm feeling bad. Well, no, you don't. You just feel bad. It's okay.
There are hormone specialists, though, who are going to test your hormones,
Mm-hmm.
and they're going to say, you need this because your estrogen is this. But the reality is there is actually no set value
Right.
that we know will make anyone feel better, that we know will lower their risks for any type of disease. We don't have that information.
Yeah.
But what we do know is what the patient is feeling.
But it will cost you a lot of money to have those labs drawn on a regular basis.
I mean, are there some labs that are worth drawing? I guess that's the question. Is there?
Absolutely.
Yes.
And, occasionally I don't see a problem with drawing a baseline lab. I get a lot of primary care specialists that refer to me because they draw labs and they're like, her estradiol level's 900. She probably has an ovarian tumor. And I think
have a hard time with that, though.
I think that's a lab error.
If you draw it and you get it and it's up here, what are you going to do with that?
Well, if it's really high, we can get an ultrasound and look for any sort of ovarian mass.
I mean, it can happen.
I've never diagnosed ovarian cancer that way. Usually those patients get referred to me because their primary care is like, I don't know, go see somebody, you probably have ovarian cancer. And I think that's probably a lab error. Let's repeat that. And if it's still high, we'll get an ultrasound. But generally speaking, no, I don't. We look at a woman's symptom. In fact, I think it's more important to do comprehensive general health panels. Because a lot of the symptoms associated with menopause are also the symptoms associated with hypothyroidism.
Right. So you're going to be testing the thyroid hormones.
I'm going to test her thyroid hormones. I'm going to test a fasting insulin, her hemoglobin A1C, a metabolic panel, CBC, vitamin D. Good grief. So much of that comes from vitamin D deficiency.
Where it's cold for a long time.
And make sure, that we're not looking at with such a narrow lens at a person. We need to be looking at them and all of their health in order to optimize it. Yes, she probably needs, and we'll talk about the reasons why women could and should be on hormone replacement therapy.
I think we're going to talk about that.
Yeah, I think that's part of the plan, right?
We will talk about that, yes.
In order to optimize that therapy, we have to look at everything. Because what's the point in giving her hormone replacement therapy if her thyroid's not optimized or a vitamin D is not optimized? We want women to feel well all around.
And I think the simple answer is you don't just show up, draw a couple labs. It tells you all the answers to what's wrong in your life. And here's the drug for you.
Yeah, wouldn't that be cool, though?
That would
if
be nice.
anything in life were like
it was that simple.
Yes, it would be a lot faster to deal with it that way. The reality is
different than every other reality.
Is we need an opportunity to see what is going on in your life. And then that helps. Part of why I'm so excited about this is we have the opportunity to actually do that. We can get more information. We can really actually help on a bigger level than, oh, here's a number, here's a pill, see you in a month or see you in a year. Like that, unfortunately, is a little bit how, unfortunately, Western medicine is right now. And,
it is.
And we want to do better than that.
Yeah. So the short answer is we're gonna look at labs, but that's not going to tell us about your female hormones.
Yes, that's not all the answers.
That's not going to tell us what to do for you.
There is not a number that gives you all the answers. That's a great response. Thank you. So since we're talking hormones, I think a good thing to bring up would be the Women's Health Initiative study. That unfortunately has set us back quite a bit. I remember when it came out, I was in med school. It's 2002. And basically, we scared women into taking hormones because it was going to cause breast cancer. I guess that would be kind of the next question is, I have patients who say, hey, can I take hormones? It sounds like they're dangerous. Like, I feel like I shouldn't be on them. When I took birth control pills once, it made me sick. Like, should I be on hormone replacement therapy? And what is the danger of the Women's Health Initiative?
Well, let's talk about the Women's Health Initiative.
All right, let's do it.
Because the Women's Health Initiative was a massive study. It was an expensive study. It was the study.
It was
that
big.
Was done looking
it
at
scared everybody.
Hormones.
Oh, they put the fear of God in us in school.
Yes.
Yeah, same.
Yes.
Yeah, and it was even on the news.
It changed the way everyone practiced.
Yeah, it was.
But it was a big study. It was a randomized controlled trial that came out. It had an arm that had a group of women that were given estrogen, and the estrogen that was given at that time was Premarin, just because that was the most commonly prescribed hormone at the time.
Mm-hmm.
So in the estrogen group, these were women who had a previous hysterectomy, because if you haven't had a hysterectomy, you cannot take estrogen alone. And so, and reason for that is because there can be increase in uterine cancer. And so if you have a uterus, you have to have progesterone as well.
Right.
But this arm of the study, these women had hysterectomies, and they were given Premarin or a placebo. And then we had another arm of the study. Those women had not had a hysterectomy. They were given Prempro, which is Premarin plus Provera, or again, placebo. And they excluded women who had hot flashes, because if you have hot flashes and you get the hormone, you're likely going to realize you're getting non-placebo medication because your hormones, your hot flashes are going to improve.
Yeah.
So we had a group of about 160,000 women, average age of 63, meaning that these women are on average 12 to 13 years postmenopausal. So they've been 12 to 13 years without estrogen or with significantly lower levels of estrogen, which I think is an important thing
so I
to
think
comment
that is
on.
important. These are not women who are just transitioning into menopause.
No.
This is women
They've been 12 to
several
13
years out. Yeah.
without estrogen. And it's during that time that we see disease occur.
Right. And we lose a lot of the benefits
Exactly.
of the therapy for sure.
So primary outcome was cardiovascular disease, which I believe came back showing it was it didn't improve.
Didn't improve like they'd hoped.
Didn't improve, but it didn't.
Because historically that had been kind of what
it was a new
hormone therapy was used. They were hoping was causing improvements for cardiovascular health.
Right.
And so they were hoping to prove that.
But this study came out, again, average age of 63, came out showing a neutral risk for cardiovascular disease.
The average age of menopause is 51, not 63. So I think that's an
we
important.
don't actually consider women who are more than 10 years post-menopause to be good candidates for initiating therapy anymore.
No.
So it
kind of loses the
number of flaws.
Yeah.
One thing that came out, though, is it did suggest a lower risk of colon cancer.
That's right. So we got one benefit.
And we're all against colon cancer.
But this study comes out and it says there's an increased risk of breast cancer
and
in the estrogen and progesterone arm after 5 years' time.
And I think they even use medroxyprogesterone in that as well, which is a very synthetic form of progesterone.
That's Provera.
And I think a lot of us feel like that may be why that increase in breast cancer was because of that particular type of progesterone.
Any of us use medroxyprogesterone anymore.
No.
I think that's a very archaic form of
practice. Because in the estrogen arm, I don't think they had an increase in breast cancer.
Lower risk of breast cancer, I believe.
Right.
Which is so different than what everybody believes about this study. It's different than what was publicized. It's different than the public.
But that's what they did. They came out and it was very public and they announced that estrogen causes breast cancer.
Yeah.
And so everyone stops prescribing estrogen.
Poor women who had been on it got removed.
It stopped.
Yeah, and we're miserable. It was kind of a sad moment for Western medicine,
and so we go, this was 2002, 20 years down the road, a significant number of women that are suffering from lack of estrogen, not being treated, saying you just need to deal with these symptoms that you're having. It's just a part of life. But luckily, it's been looked at. Recently.
And many studies since then. Unfortunately, that haven't gotten nearly the publicity that the Women's Health Initiative.
It's coming. It's coming.
It's coming out. And I think that's the important thing is we are learning from our mistake. And the reality is that study had a lot of flaws.
It did.
And unfortunately, it dictated how we treated women with hormones for quite some time. And we're improving. And we're a little slow to get there, but we're getting there.
The American Cardiac Association has come out and they've looked at the study again. And they looked at the group of women, like you were saying, who were between the ages of 50 and 59. And those women who were started on estrogen actually had a lower risk of cardiovascular disease. They had a lower risk of death from cardiovascular disease. Which is among the top 3 number one killers of women. It is the top killer for women is cardiovascular disease. So that was a good finding. But one thing that I do like to mention to women is, do we ever talk about increased risk of breast cancer if you're pregnant too many times? Do we talk about that? Because guess what? When you're pregnant, your estrogen is at its highest.
True.
And we never tell women you should probably not get pregnant again because your risk of breast cancer is going to be higher.
Well,
don't you think 3 is enough?
Well, the interesting thing is the increase wasn't even that much. Wasn't it like from 1 in 1,000 to 2 in 1,000? Like it wasn't even a huge change.
And among the progesterone containing, there was a decrease in the risk for breast cancer among the estrogen only arms.
Right.
So
it was
the
just
way
the
that this study
combination
has
arm.
been misrepresented and the proliferation of this, false data is profound.
Yeah.
And what it's done to the way we care for women, their quality of life, and their risks for long-term cardiovascular disease and
it's devastating.
Diabetes, osteoporosis.
I mean, I was in residency when it came out.
Yeah.
I did not give hormones. It's taken a long time for me to become educated.
It was use the least amount for the least amount of time that you could possibly use.
Yes. And you don't get it. You do not give it to lower cardiovascular risk. You do not give it to lower risk of colon cancer. You do not
Or
give it for those things.
osteoporosis.
It is not indicated for any of these things.
I know. If you think about the big killers of women, it's cardiovascular disease. You worry about Alzheimer's. You worry about risk of fracture.
Bone fractures. Yeah.
Those are the things that really scare us.
Urinary syndrome.
Yeah.
So,
which is, I mean, the number of women we talk to about vaginal pain and genital urinary issues, over the age of 50, and the misery that causes. Is it going to kill them? No, but the quality of life.
The number
is amazing.
Antibiotics I called in for my grandmother for urinary tract infections was probably a lot more than I would have had she been on vaginal estrogen.
Fair enough. So maybe let's just do a quick rundown of some of the benefits of hormone replacement therapy. And then we'll actually talk about what hormones are involved in hormone replacement therapy. But maybe let's just generally talk about some of the things that you can expect that hormone replacement therapy will do to help benefit your health.
Yeah. So I think one of the things that's really important to address when we talk about perimenopausal symptoms is that everybody talks about hot flashes and night sweats. And those tend to be the big symptoms that everybody brings up that are well publicized. But other symptoms of menopause are brain fog and mood changes and other sleep disturbances, difficulty maintaining muscle mass, increase in central adiposity, that weight gain in the abdomen, and your visceral fat, that is the kind of weight gain that increases your long-term risks for cardiovascular disease and diabetes. Sure. And I think the most common phrase that disturbs women really early in menopause that I hear is, I just don't feel like myself anymore.
Right.
And it's probably
That's the same woman who says, can you check my hormones?
Yeah, can you check my hormones?
I think I said this to you about a year ago.
Yeah.
And you were like, are you on hormones? And I was like, no. Yeah, should I be?
It's time.
All the other symptoms that women have, the most distressing one for them is the one you don't read about in textbooks because it's so difficult to define. It's difficult to quantify, but this feeling of I'm just not who I used to be. And a lot of that has to do with these fluctuating and declining hormone levels. Right. So the benefits include improving your quality of life, which is devastating the quality of life that women have been denied since the Women's Health Initiative came out, but also all those things that we talked about in the long term. We focus on breast cancer. And all my patients are so concerned about breast cancer. Well, what about the risk for breast cancer? And I think, first of all, that's not true. Second of all, breast cancer is likely not what's going to kill you. Right. It's the cardiovascular disease, diabetes, osteoporosis, and dementia. And we can dramatically influence the long-term risks for a woman in those. So improved quality of life now, improved quality of life later.
And looking at cardiovascular disease itself, we have so many patients that come in who are in their 50s and their 60s, and they're on a statin. And if you look at the research,
or blood pressure medicine,
right? Yes. But statins have not been proved to lower cardiovascular or lower the risk of death from cardiovascular disease.
And have a long list
but
of side
estrogen
effects.
has.
Yes. And estrogen's more effective at treating and preventing osteoporosis.
Yes.
Yeah. If you really look at the numbers, when it comes to cardiovascular disease, women catch up with men when they hit menopause. Before then, they're much less likely to die of heart disease.
Our statistics
and that
dramatically change.
There's a reason for that.
That healthy self hypothesis, where they talk about estrogen being better at preventing disease than treating disease. And so if we start a woman on estrogen, even before they start to have symptoms, and certainly before they develop cardiovascular disease, we can prevent that disease from happening, because estrogen, it treats the neural cells, it treats the intima and the coronary arteries, and can actually lower the chance of disease occurring if we start it early enough.
Yeah, and I think that goes back to the point you made about the Women's Health Initiative study starting at age 63, is a lot of the benefits that we get from hormone therapy seems to really be affected by how early someone started on it. So if we wait until you're 63, unfortunately, we've missed our chance to really have the most
not
impact that
100%.
we can.
Not
We haven't
100%.
missed the boat totally.
But we've
But
missed
to a degree
opportunities.
that's devastating and neglectful on our part
So
as
things like
practitioners.
Alzheimer's disease, unfortunately, if you miss that opportunity, you miss the chance of preventing that. Cardiovascular disease, osteoporosis, like these are really, really big factors for women as they age. And, people are living longer. And the last thing we want to do is have people living longer miserably. Yeah, we want you to enjoy life for as long as you possibly can. So I'm hoping that our push going forward in medicine in this country is to actually say, hey, we want people to live long, but we want them to live healthy and full lives where they're active and doing things that instead of just unfortunately being in bed or in a facility because they can't function or they broke a hip or something that's really been a negative impact on their life.
And that being said, I don't want there to be like an age that comes across to anyone that if I get to this point, I'm past. I can't seek help.
We have
I
a
have
lot
a
of ways.
74-year-old woman who came and saw me earlier this week. Her children were like, Mom, I think you need to go and just see.
Right.
And it's a different conversation with a
For sure.
74-year-old versus a 45-year-old. There are different risk factors that we need to account for, different tests that might need to be drawn to see what her level of risk is. But there's not an age where there's no hope
where it's
for
hopeless.
you.
Right.
Yes.
Right.
Yes.
Right. And besides hormone therapy, there are other things that we can talk about and help to improve quality of life. But this is just kind of our focus today. So kind of wanted to hit on this a little bit. Well, speaking of hormone replacement therapy, I think it's important to talk about what it is. Like, what hormones are we talking about? I don't know who wants to tackle that one. Do you want to do that one?
Have at it, Tennille.
I'll start. So typically when we're talking about hormone replacement therapy, we're talking about estrogen and we're talking about progesterone.
Yes.
Starting with estrogen, we've got the oral forms and the non-oral forms. The oral forms are not my favorite just because they have to be digested. They travel past the liver, and as they pass the liver, they can increase clotting factors and can increase their risk of blood clots. And so that's, I'm sure.
It feels like most of
probably not the
the
preference.
current evidence is pushing towards
Transdermal.
a transdermal approach.
Right. So the
estrogen.
non-oral forms, we can do
Right.
patches, we can do creams, we can do sprays. There's also a vaginal ring that can be used, which is really nice because it's going to target the vaginal tissue as well as systemic estrogen, but it's apparently pretty expensive.
Yeah.
So
cost can be a factor.
It is, yes, it's something we consider as we're trying to decide what's best for a woman. But estrogen, we try to use the body identical, or some women like the term bioidentical form, which can be from a regular pharmacy or from a compounding pharmacy, either one. Yeah. But estradiol is kind of giving back your body what it used to make.
Seems like the workhorse really of everything is estradiol.
Yes. And then we have progesterone, which progesterone is a hormone that women have to take if they don't, or if they do have a uterus. But you probably would agree, a lot of women, you say, okay, you have to take this progesterone for at least 2 weeks out of the month to protect your uterus so that the estrogen we're giving you does not increase your risk of uterine cancer. But they then come back for your follow-up appointment and they say, can I take that progesterone every day? Because it's helping with my anxiety and it's helping me sleep better and I just feel better on the days that I take it. So yes, guess what? You can take progesterone every day. Yeah. And again, we're trying to give you back the progesterone that your body makes. Unfortunately,
yeah.
What's that? I said, take it at night.
Yeah.
Yes, take it at night because it will help us
I usually
sleep.
recommend my patients take it at night for sure.
But we're not able to do the progesterone through a transdermal route like we do the estrogen, just because the body identical form is too large and your body can't absorb it. So we do oral.
But I think that's really important too, because I get a lot of patients coming to me with prescriptions from, hormone specialists or, some other places that provide these prescriptions, and they are getting preparations that have the transdermal progesterone in it. And
if it's a different progestin, then that's different, because there are some progestins that can be absorbed transdermally, but if it is micronized progesterone, they need to know that they are
bioidentical.
They need to know that they are not protecting their uterus.
Yeah.
So the forms that you're getting in a transdermal preparations are different than the bioidentical oral forms.
Right. Yeah. Progesterone, unfortunately, is just not one that we've done a great job of being able to get that one transdermally.
And there's not really a point either, because there's not additional risks associated with the oral form like there is with estrogen.
The struggle comes in, you have to take two. Mm-hmm. You've got to do your estradiol and you have to do your progesterone as a separate prescription and a separate pill. But there's no increased risk with doing it that way.
Mhm.
What about testosterone?
Well, I thought that was for a different podcast, but
I get that
testosterone is
question
one of my favorite hormones.
You can just be brief. We could talk about this more at another time, but just
I got a spiel for that one too.
Okay, good. This is a good-
Testosterone, I think, is very important for women in multiple different ways. I think testosterone is important to help with mood. It will help with sleep, and it will certainly help with your ability to maintain muscle as you age. I think testosterone has a stigma around it that brings fear to some people, but I think there are actually a lot of people who are opening their minds and realizing that testosterone actually can be beneficial.
There's a lot that's clearing up about testosterone. Unfortunately for women, there aren't a lot of studies, and there is no FDA-approved version of a testosterone prescription that's designed for women in the appropriate doses, so it gets a little more complicated. And I want to point out too that the bioidentical estrogen and progesterone, I have a lot of patients coming to me saying, well, I had to find a different person to, a more natural doctor to give me that because, I have to get it from a compounding pharmacy. And there are FDA approved versions, and it makes a big difference for people of bioidentical estrogen and progesterone. And it makes a big difference for people for whom the compounding forms are cost prohibitive. Your insurance will cover them. But when it comes to testosterone, you have to use a compounding pharmacy really because there aren't doses that are appropriate for women. And the way that testosterone is produced in the body is different than the estrogen and progesterone. Rather than a really abrupt cutoff, around menopause, there's a slow and steady decline from around the age of 30. And about 75% of our testosterone is actually produced in our adrenals. So there's this slow, steady decline. It does change a little bit after menopause. But there are some, the benefits are a little bit different. And a lot of it has to do with postmenopausal hypoactive sexual desire. There is some reasonable evidence for that. But the muscle mass is huge.
Yeah.
And the mood. It really,
energy.
You have a lot of people who have depression, who are you're already giving an SSRI. You give them estrogen and progesterone, and eventually it's like, okay, well maybe we need to look at testosterone.
Yeah, and I like to do it that way too. That same way, start the estradiol and the progesterone, so we know what your side effects are, so we know what your dosages are, and then when we add the testosterone, we know if some of those side effects are associated with the testosterone or the estrogen, or we can differentiate the side effects there.
Yeah, and I think it's important to realize that men and women are very different on testosterone. So the amount of testosterone for men is at a very different level than women. And unfortunately, we do sometimes get patients that show up and they're getting male doses of testosterone. And I'm like, oh, that's a lot of testosterone for women. So it can cause some pretty dramatic side effects when we're at those type of doses.
It has to be done right.
Yeah, it has to be done right. And that's kind of what we're hoping, is to try to create an environment where people can safely get these type of medications. And we are very comfortable working with compounding pharmacies. We're comfortable using regular FDA-approved medications that our insurances will cover. So kind of back to our philosophy of trying to meet patients where they're at. I feel like that's kind of one of the things that we really want to try to be available is, hey, if someone comes in and says, this one works for me, that one doesn't, we want to try to work with that and try to find a way to kind of meet someone at the level where they feel comfortable with the healthcare they're getting.
Right. Yeah, I think our local compounding pharmacies, I am on a first name basis with them. I'm always calling them and being like, no. But for her specifically, she's a breast cancer survivor.
Yes.
And this is what's happening. But she has a sensitivity to this particular component. And we can work really closely with them.
You're able to tailor it to a specific woman. Yeah. It's not a one size fits all.
Yeah. So I think if I would briefly summarize the typical hormone replacement therapy, we're talking about estradiol, which seems to be the workhorse, progesterone, which is definitely protective of the uterine lining if you have a uterus, and does have some other benefits that I think all of us have seen. And then for some patients, also testosterone. So those are kind of the three that I most commonly associate with hormone replacement therapy, kind of when I'm taking care of my patients. That feel pretty fair for you guys? Yeah. Okay.
And whether we want to include it or not, testosterone is one of the few hormone levels that I do draw periodically. Just because a woman does not need to be on physiologic levels of
and
testosterone.
that one is not like estrogen. It's not going to fluctuate like estrogen does. That is a little bit more stable.
It's easier to quantify. It's a little bit more reliable. And I want to make sure that I'm not deepening a woman's voice in an unnatural way. And,
facial
some
hair,
of those,
acne.
some of the symptoms are not reversible. We just don't love that.
So that's, very good. I mean, speaking of dosing, I think that's a pretty good question I get a lot. How do you know how much estrogen to give someone? How do you know how much progesterone to give someone?
And I would again say there's not a one size fits all.
Mm-hmm.
Like how you're talking about speaking specifically to your compounding pharmacist about a patient and her specific needs. There's not a one size fits all. There are not any studies that tell us this amount of estrogen is going to lower the risk for cardiovascular disease. It's going to protect from colon cancer. It's going to lower risk for osteoporosis or dementia. We don't have that information. Hopefully it's coming.
Right.
But we don't have it right now. So right now we have to take a woman as an individual, talk to her about her symptoms and figure out a starting point for her. If we have someone who maybe does have acne, who's maybe having some irregular menstrual cycles, then we may want to start a little bit higher dose to try and manage those symptoms. But if you have a woman walk in the room and she says, I'm actually feeling pretty good. My periods are normal. I'm still having them. But I do know that that I want to lower my risk for cardiovascular disease and for insulin resistance. And I don't want this brain fog that I hear my friends talk about. Right. We're going to start her to lower dose and then titrate through time as they need.
And I think that's the important part about follow-up, right? Is we're not treating a number. We're not treating a piece of paper.
See it for your next pap smear in a year.
Yeah, we're hoping to treat someone how they're doing and find out, okay, is this dose working? How do you feel on it? And so having them come back and see you and be able to go through that, I think is really important. To getting the right dose is you have to be able to see someone and see how they're doing and find out how it's going.
And it's important for women to know too, we might get you to that dose. We might get you to where you're feeling amazing. And guess what? Your body changes.
6 months come
it might be a year down the road. It might be 2 years down the road. I don't know. But time passes and your body changes and you might start to not feel as well. And at that point, then, okay, we reassess. We talk again.
For sure.
And we adjust as we need to.
And there are also other solutions outside of that too. I get, women coming to me and they're like, I still can't sleep. My other doctor has me on 900 milligrams of progesterone. It's still not working. And I think, oh my goodness, there are other reasons why you might not be sleeping.
Yeah.
Like we need to, I think,
evaluate
at this point,
everything and not just.
Might not be the only solution.
That's true.
More progesterone.
That's true.
Pile it on.
Well, speaking of side effects, what are common side effects you see when things aren't right, or even if they seem to be at the right dose? Like, what are some things that we tell patients to be looking for to find out if the dose isn't right?
One of the most important things I would say, when you start a woman on hormones is you got to talk to her about her bleeding. A woman who is having regular menstrual cycles, irregular menstrual cycles, hasn't had a menstrual cycle, any of those categories, she might notice a change, especially during the first 6 months. So it's important to warn her of that and say, don't freak out. This is okay. This
could be part of the process.
If there are some changes during this first 6 months, that's okay. But after that time, if you continue, you have postmenopausal bleeding or you're having more frequent or prolonged bleeding, then it does probably warrant a workup with maybe a biopsy and an ultrasound.
Requires just a panty liner? Are you wearing more than that? Is it a couple of days versus a couple of weeks?
But there can be an initial change, but that should settle and you should get back to your baseline after about 6 months' time. After that, it probably should be looked at just to make sure that there's nothing going on.
Okay.
And then I'd also say headaches, migraines, right? You have new onset migraines. That's maybe something that you should look at.
I think the most common non-medically concerning symptoms that I hear are some changes in acne that are pretty brief. It gets better. And bloating. Yeah. A little bit of abdominal bloating.
Yeah, I definitely think the tiredness too. That's why I like using the progesterone at night. So I think of the hormone replacement therapy that I've seen is some women do complain of more tiredness. So using progesterone in the evening, I think is helpful.
And some women are really sensitive to it. Yeah. I'll give them 100 milligrams and they'll say, I am so lethargic throughout the day. Yeah. And some women want 200 milligrams because they're still not sleeping. So it's highly dependent on the individual.
Yeah, I agree.
And then some women, if we're doing transdermal estrogen, some women might have an allergic reaction to the adhesive. And that's actually, I've been really surprised. I don't know if either of you know about using, what's the nasal spray?
Flonase?
Flonase.
Oh, Flonase.
If you put Flonase on your skin before you put the patch on, and you won't have that reaction.
I think probably a good question to ask. And I have patients that just don't know at what age even to be worried about this. Like, at what point should you go to your doctor and say, hey, I'm not totally sure if I need to be on hormone replacement therapy, or do I need to have this evaluated? Do I wait till I'm 55 or 63, or is it when I'm 25 or after having a baby? Like, when should I have this conversation?
Well, the answer to that is whenever you think it. I'd say at least by the age of 40.
Okay, I think that's fair. And I think it is different for everyone.
It is different. Some women, occasionally I diagnose a woman with premature ovarian failure at a much younger age, and they come to me, and it's not very common, but, they start to question that. Like, man, this sure sounds like, but maybe I'm crazy, or maybe I'm a hypochondriac. And I think, no, the moment you start thinking that, you should probably go in and talk to somebody.
Right.
Right. And it would be almost catastrophic if that happens and 10 years go by and they're miserable for 10 years and they kind of miss that opportunity to have the benefits. It's kind of sad.
And then there are risks for osteoporosis increase.
Right.
And,
What women don't realize is that your estrogen is declining when you're in your 30s. I was not thinking about that.
I was invincible then.
I mean, most of us are not thinking about that.
I thought you were still in your 30s.
Oh, yes. But we're normally in the throes of life, and we're taking care of children, and we're not even thinking about our own health at that point of life. But the reality is, a woman is born with all of her eggs, and it just declines month by month.
Yeah.
We get to age 30 and we're at about 10% of our eggs. We get to 40 and we've got 3% of our eggs. That's wild.
Yeah, it really changes.
And so
quickly.
for a woman to realize that her hormones are declining steadily, and by the age of 30, yes, they're starting to go down. It doesn't mean that you have to seek out hormone replacement therapy at that age, but it shouldn't be something that's frightening for you.
It's a discussion that should be had.
If you think about it, then yes, it should be a discussion that you have, because you don't necessarily want to wait. You can wait, but you don't necessarily want to wait until you're suffering.
Yeah. And the other point too, and part of this comprehensive look and detailed look into a woman and her health as an individual is that if she's feeling that way, come in and talk about it. And maybe your hormones aren't off. Maybe it's not your estradiol and your progesterone. Maybe we look into it and you have thyroid hormone dysfunction.
Maybe it's your lifestyle.
Maybe you have some mild insulin resistance, and it mimics some of those hormonal effects. And, maybe the solution is just different than we thought it was.
Yeah. Or maybe we have to focus on your nutrition and your exercise and some other parts of life.
Something novel like that we don't have time to address in common medical practice.
That's true. Yeah. I think probably the bottom line is nobody's a number. You're not. No one has to fit into this perfect textbook definition of when menopause starts. It can be different for everyone a little bit. So that's why just having the conversation is helpful, and just reevaluating, like, how are you feeling? How are things going? And I think that gives us a platform to kind of work off of is being able to just have the conversation.
Love it.
Okay. I have a few more little questions just to bring up. I think this is important. What kinds of things should I be worried about? Like, what makes me not a candidate for hormone therapy? Can anyone just do it? Or are there a few things that do put me kind of at a little bit higher risk of being treated with hormone replacement therapy?
So what we're coming to find, all of the research and the data that's been available since the Women's Health Initiative, is that there are very few people who are not good candidates. Almost everybody is a pretty good candidate for hormone replacement therapy. And for those who aren't, those few people who aren't, we do have some alternatives. So women who have genetic mutations that increase their risk for blood clots, or who have a personal history of blood clots, like you have a pulmonary embolism, you had one in your 30s, like you might not be a great candidate for estrogen. Or at least
I might disagree with that. I do believe that you can be a candidate for estrogen as long as you use the correct route.
Right. As long as you use the correct route and you understand the risks, right? So for I have a patient that had a stroke in her 30s.
Yeah.
But, all of her specialists, so on paper or according to my textbook, she's not a good candidate for estrogen therapy. But according to all of her specialists, the reason for her stroke was different than the typical person who wouldn't be a candidate. And they all signed off on it. And so now she takes transdermal estradiol preparations, and we use low doses, and the risks associated with a transdermal preparation are much lower than those associated with an oral preparation.
And this probably occurred because you had a conversation with this woman about...
That lasted longer than 5 minutes.
Probably. But you talked about her risks,
Yes.
and you talked about her benefits.
And then
she
you
made
gave her the
decision.
option.
Yes, she made a decision that she felt was best for her.
As a grown woman,
recognizing what her risks
intelligent.
are.
Yeah.
I mean, I think the ones that jump out at me are like someone who's had breast cancer and been told it's estrogen and progesterone receptor positive.
Right? I do not think there is any woman who does not deserve the conversation.
Right.
I think every woman deserves the conversation. And yes, there are some women who might choose not to use hormone replacement therapy because they might decide, yes, my fear of getting breast cancer again, if I were to use estrogen, is higher than my fear of osteoporosis or of cardiovascular disease. But at least you've had that conversation with her and you've given her all of the data.
It's an informed decision.
And let her decide.
Yeah, because I have had the same scenario come to me, who has such a strong family history of cardiovascular disease that she was willing to accept the risk of breast cancer and reduce her long-term risk of cardiovascular disease.
Well, yeah, and the reality is most women don't die of breast cancer. They die of heart disease.
The survival rate is quite high for breast cancer.
Yeah,
right?
And so I think the conversation's important. We can't eliminate all risks. And when you balance the risks on both sides, hormone replacement therapy versus not, most of our studies are showing all-cause mortality is reduced with hormone replacement therapy, even in these higher risk categories, which is interesting. It is still important to have the conversation to realize, hey, yeah, this is a possibility that this is going to increase your risk of getting a breast cancer again, or of cardiovascular disease, or a stroke. Like, it is possible. And I think it's important to understand those risks and also understand where the benefits are. And
the other thing is we do have other options. We have SERMs, the selective estrogen receptor modulators that we can use. So if we have a woman who's had breast cancer, one of them is Duo-V that can be used, and that's got a combination of medications. One that's going to bind to the estrogen receptors and block them in the uterus and the breast, and then activate it in other areas. So there are other options for women who might be concerned about their level of risk for things like breast cancer.
Have the conversation and have it with someone who knows. Unfortunately, there's a lot of people out there that just don't have a ton of training in this area. So I think having that conversation with someone who's got some experience with some alternatives, with what's out there, and then knowing, if we weigh all the pros and cons, now you can make an informed decision that's best for you.
Right.
Does that feel fair to you guys?
Yeah,
I do.
Yes.
Totally agree.
Okay. I think another good question is just what resources are out there? Like, what, if I'm trying to get more information, where do I go to get more information?
This is a tough one for me. I will be honest. I did not even know how to answer this, but the menopause.org, that's the only thing I could come up with.
Yeah.
As a good resource.
The North American
so
Menopause Society, now known as the Menopause Society.
Yes.
I think it's important to know that they're the same thing. But you like the new menopause.
I do
like
the
the
new
great
menopause.
one.
I thought she did a pretty good job explaining it at a level that's science, but also relatable to someone who doesn't have a science background.
Yeah.
Right.
And I really liked Estrogen Matters for somebody who's like, oh no, I want to geek out a little bit more.
I think the hardest thing is nobody can create something for everyone. So like the way you read information, it just has to be a question answer. Like, I feel like the importance of having time with a patient is to really go over their specific situation and tailoring things to them individually. So much in medicine is designed around trying to fit everybody into a box just because that's the cheapest way to do things. I just don't feel like that's always the best way to take care of someone.
Not even ever the best way. I even if somebody's pretty low risk, trying to fit them in a box, and I think that's what's important about what we're doing. is even for somebody who's really healthy, who's super fit, who has
have
this
a way to
perfect
help,
lifestyle.
Even improve their super fitness.
Right? We can even optimize that. That's a different podcast. But to make sure that we're sitting down with even that person who fits into the textbook criteria, and we're saying, yeah, but tell me about you. And tell me about your sleep quality, and tell me about your relationships and your marriage and your partner and the way you interact with your children and the time you have to exercise and the kind of exercise you like. And, maybe you have a different spiritual or religious practice that influences the decisions you make about food and the decisions you make about your relationships. And how does that play in to the prescriptions we provide you and the recommendations we make about vitamins that are going to optimize the prescriptions that we give you.
It really is comprehensive care that we're hoping.
Yeah. And that kind of approach that's going to be different than what you get anywhere else that you go, because not everybody's going to fit in the textbook criteria. Right. And even those that do deserve that kind of personalized approach.
Right. Well, thank you. I think that was a very good discussion. I appreciate your guys' time and information. I think this is really helpful and hopefully is valuable to anyone listening. And we will try to tackle some hard topics kind of going forward. We're excited to try to kind of talk about it and go through it, and then hopefully have opportunities to take care of people and maybe help them improve their quality of life.
I would agree.
Okay.
Thanks, Sean.
Yeah, thank you.
Thanks, guys.
Yeah, and if you want more information, we do have a clinic. It's called the Valley Hormone and Wellness Clinic. It's located in American Fork. We do have a website where you can get more information. These podcasts will be on the website, so there's other ones you can look into that you have questions about. The website is www.valleyhawc.com.